Hello, and welcome to another in our series of informational seminars. My name is Terry Cunningham, and I am the president of the board of directors of the Liver Coalition of San Diego. We are presenting these seminars to inform you about liver diseases, and we have experts who provide extremely useful information. The Liver Coalition was founded last year to fill the void created during the pandemic. Now, all funds raised stay in San Diego and do not go to a national organization. Please check our website for other webinars and information that is very important. And thank you for attending. We have a list of sponsors that I would like to introduce now. And first, we will start with Excelsis. And we have a slide for that.
Hi, everybody. I'm Susie Emmel. I am the account manager in San Diego for Exelixis, and we are proud to be sponsors tonight and just want to thank the Liver Coalition for putting on these talks. Thank you.
Thank you, Susie. Appreciate it. Next is Intercept, and we want to thank them so much. And we have Gilead is also being a sponsor. And we have Dynavax, and Carl Bazante is going to do a little presentation.
Thank you, Terry. I appreciate your introduction. Thank you, Scott, Dr. Patton, Melissa, everyone involved. At Dynavax, we are very, very focused on the liver community. We very recently came out with a 2-dose, 1-month hepatitis B vaccine. And as you all may know, hepatitis B has no cure. So vaccinations become crucial. And in this time of vaccinations being so important, it really does give us a great deal of pleasure to support both the Liver Coalition and the community in San Diego. So thank you again. Thank you for presenting tonight, Dr. Patton, and Terry, back to you.
Thank you. We have a short video from AbbVie that will be presented now. And we also have a short video from Asahi. And again, I'd like to thank all of our sponsors. Without your help, we would not be able to put on these seminars. And they are incredibly important for our community. Now I'd like to take a moment to introduce Melissa Ferrari, who is the moderator for tonight. And she is the co-chair of our Associate Medical Advisory Council. So take it away, Melissa.
Thank you, Terry. Hi, everyone. Thank you for joining us. My name is Melissa, and I'm our moderator. So a couple of housekeeping things before we get started. During the presentation, you may have questions, and we'd love to field them. So if you could go to the right side of your screen, there is a questions tab. You can type in your question there, and it will be brought to me. I'll then decide if it's appropriate to maybe field that question immediately, or we can hold it to the end of the presentation, where we'll also have some time for question and answers. Without any further ado, we would love to get started. So I'd like to introduce Dr. Heather Patton, who is within the VA of San Diego's healthcare system, and she's going to be speaking to us tonight about hemochromatosis and how it affects our liver. Dr. Patton?
Thank you, Melissa. Thank you, Terry, and thanks to the Liver Coalition for the opportunity to speak with you all today about hemochromatosis. Bear with me, just getting used to my screen share view here. Okay, so let's get started. The term hemochromatosis is originally credited to a German pathologist in the late 1800s after he recognized this condition where the organs were pigmented, and he attributed this to a factor circulating in the blood. So in order to discuss iron overload, let's start by just going over how iron enters the body. So most of our digestion, or most of our absorption of nutrients, including absorption of iron, occur in the early portion of the small intestine called the duodenum. And you can see in the blow up here that this portion, the lining, has all of these finger-like projections to increase the absorptive area. And so under normal circumstances, the amount of iron absorbed in this region of the bowel is about 1 to 2 milligrams a day, which is a relatively small amount. In contrast to iron absorption, there isn't a sort of normal mechanism to excrete iron from the body, no physiologic process, if you will. In women, due to menstrual blood loss, there can be some offset of the iron that's absorbed, and it can occur in pathological conditions. So for example, if somebody has gastrointestinal blood loss, this can offset the iron absorbed. But otherwise, there's no way to get rid of it once it gets into the body. And so the regulation of that absorption of iron is really critical in order to keep from ending up with an excess of iron inside the body, which you cannot then get rid of. And where the liver comes into this is that it is important in the process of regulating iron absorption. So in this cartoon here, you can see the top here would be the intestinal contents that would include iron from the foods that we eat. That iron gets absorbed through the cell surface that has all of those finger-like projections, and then enters the inside of the cells lining the intestinal tract. Whether that iron exits those cells into the bloodstream is where the liver really comes into play here through this hormone that's called hepcidin. Once the iron does enter the bloodstream, it's carried within the bloodstream by a protein called transferrin. So this hormone, hepcidin, I'd like to think about as like the brake pedal for iron absorption from our intestinal tract. So hepcidin is made within the liver, and it's released in response to the amount of circulating iron levels. So if there's too much iron present in the body, then that level of hepcidin released is going to be increased to really cut back on the amount that's allowed into the body. If there's iron deficiency, then the levels of hepcidin are lower so that more iron can be absorbed to help make up for the loss. We also can see a response to systemic inflammation in the body can result in higher levels of hepcidin, and in that setting, decreased amount of iron absorption from our intestinal tract. So how do we evaluate the amount of iron in the body? There are two main lab tests that we check to monitor this. The first is the serum ferritin level. So ferritin is a protein that contains iron, and the normal levels in premenopausal women are under 200. In postmenopausal women or in men, it's under 300. This ferritin level can also be influenced by systemic inflammation. So in the presence of inflammation, we'll see higher levels of ferritin. The other lab that we check to monitor iron status is the transferrin saturation, which is calculated from the serum iron level divided by what's called the total iron binding capacity. And this result is reported as a %. And when we look at people's iron panels and see a combination of a normal ferritin level with a transferrin saturation under 45%, that's very reassuring to us if we're trying to evaluate for presence of iron overload. So if both of those parameters are met on the blood test, then we can feel confident that this individual does not have an excess of iron. So in discussing iron overload, there's two broad categories that can occur. The first we call primary iron overload. So these are inherited conditions that affect the normal iron metabolism that we just reviewed and related to specific gene mutations that influence this process. The other category is secondary iron overload, and this can be either circumstances where somebody is dependent upon blood transfusions or has gotten some excess of iron delivered, typically intravenously, or also in the setting of other conditions that can influence this whole process of iron regulation, often mediated via specific types of inflammation. So we're going to focus most of our discussion on what's called type 1 hereditary hemochromatosis. This is the most common inherited condition that results in iron excess. And this is caused by mutations in what's called the HFE gene. So recall, or I will introduce you if you're not familiar with this. For each gene, we have two copies, one that we've inherited from our mother, one from our fathers. And for some conditions, if you have just one gene mutation, then we can see a particular disease manifest from that. We call those autosomal dominant genes. In case of type 1 hereditary hemochromatosis or mutations affecting the HFE gene, we actually need to have two mutations present in order to see the disease manifest. So this is what we call an autosomal recessive condition. If you are being tested for this condition, your doctor would send off gene analysis of the HFE gene. And typically that involves screening for 3 different mutations that are recognized. So the C282Y, H63D, and S65C. Now, when the results of this analysis come back, it will either say that no mutations were detected, or it will tell you if 1 or 2 mutations were detected. We while we're testing for all three of these mutations, there are really just two combinations that we recognize have the potential to result in significant iron overload conditions. And this is either having two copies of the C282Y. This is what we call a C282Y homozygote, or having one copy of C282Y plus one copy of H63D. And this we call the C282Y H63D compound heterozygote. So again, the majority of people we see with a primary iron overload or inherited iron overload will have mutations in this particular gene. And of those who manifest iron overload, the majority will have this C282Y homozygous pattern in terms of the mutations present. How common is this in the population? And so in the United States, we will see this this gene present in about 1 in 300 individuals. And speaking specifically about individuals who are homozygous for or have two copies of the C282Y gene mutation. This does not affect races and ethnicities equally, but you can see here that this is most commonly seen in individuals who are non-Hispanic whites, particularly those of Northern European ancestry, and lower rates seen in the other groups shown here. So again, just a little quick review of some of the terminology that we use when we're talking about genetic conditions. And the terms I want to discuss here are genotype versus phenotype. So a genotype is, what particular genes a person has or gene mutations somebody may have. So for the HFE mutations, the C282Y mutations are the genotype. In contrast, what we call a phenotype is really how that the gene in conjunction with environmental factors, lifestyle factors, result in a manifestation. And this is an important concept in all genetic conditions, particularly true for the HFE mutations and how that impacts the severity of iron overload. So one of the first questions I wanted to review tonight after that background is the question of, does everybody who has the same mutation have the same problem with iron overload? The short answer is no. And this is that concept of disconnect between genotype and phenotype. So you can look at a large group of people who all have the exact same gene mutation, but they may not develop the same degree or severity of iron overload. One of the most basic differences that we can see is by gender. So we talked about the fact that there's no physiologic way for us to shed or get rid of excess iron, but because of blood loss from menstruation, pregnancy, and lactation, women tend to present at an older age. So it takes them longer to accumulate the same amount of iron that men can. And so men will typically present at a younger age and may have more severe manifestations than we see in most women with this condition. However, even above and beyond the gender differences here, if we look at people who have the C282Y, two copies of that gene mutation, the sort of manifestation of that, having iron overload that we would measure through the transferrin saturation, plus or minus an elevated ferritin that we discussed, that's been estimated to be present in about 75% of men and 50% of women out of 2 large studies done in the US and Australia. So even among men, where this is more common, that means that 25% of them with this gene mutation may not have an excess of iron as an indication of their phenotypic expression. So again, this gets to this concept of variable penetrance, meaning if you have the gene, how often do you actually sort of express it in terms of manifesting the disease? And we know that for this particular gene mutation, that's not 100%. And that this is influenced probably by other, there's what are called modifier genes. So aside from the HFE gene, there are other genes present that may influence how this is expressed, in addition to different factors in our lifestyle or environment that can impact the expression. So we're focusing primarily on this type 1 type of hemochromatosis, but there are other primary causes of iron overload or other genetic causes of iron overload that can present a little bit differently, affect people differently. So there are some that are characterized as juvenile. So there are different targets that are mutated in the whole iron metabolism pathway, and these tend to manifest at a younger age. There is a condition called Ferroportin Disease that can present a little bit differently, and mutations in the transferrin receptor that can clinically look similar to HFE-related iron overload. Excuse me. These are not conditions that are really that we can readily test for based on their rarity. So we said that the HFE gene mutation is seen in about 1 in 300 individuals in the United States. The frequency of iron overload related to the mutations in hemojuvelin or the transferrin receptor is 1 in 5 to 6 million individuals, and mutations in the hepcidin gene are even less frequent than that. So these are fairly uncommon conditions that can result in iron overload. So just to sort of summarize here, we're focusing our discussion this evening primarily on type 1 adult onset hemochromatosis, where the mutations that drive this condition are in the HFE gene with genotypes that we have discussed here. So what about, we said that there's, in addition to this primary iron overload, that there can be secondary causes of iron overload. So these include certain types of anemia. Sickle cell or thalassemia major can result in an excess of iron release and accumulation. We can see it in individuals who may have certain types of anemia that really require transfusion to maintain their red blood cell counts because blood transfusions contain iron. If people are getting transfused repeatedly, that can result in iron loading in the body. Certain conditions that produce systemic or sort of full body diffuse inflammation like rheumatoid arthritis or lupus can result in an excess of iron. And certain other chronic liver diseases. So this can come up in the evaluation of some of our patients we're seeing who may have alcohol-associated liver disease, chronic viral hepatitis, particularly hepatitis C, and in some patients with non-alcoholic fatty liver. So this is something that we see not so infrequently in our clinical practice. So what are the organ systems in the body that can be affected by an excess of iron? Well, we're going to talk primarily about how iron affects the liver, but we can see iron deposits elsewhere in the body that can produce a number of symptoms or conditions. So this includes the skin. You can see here in the picture this increased pigmentation or bronzing of the skin. Iron can be deposited in the heart tissue, in the joints, and in some of the endocrine organs. And we'll go into detail about some of these here. In terms of symptoms that may bring patients to their doctors for testing that may lead to diagnosis. The most common things reported by patients are fatigue and arthralgias or joint pain, joint aches. So let's talk a little bit about how the endocrine system can be affected by iron overload. Iron accumulation within the pancreas that contains cells that produce insulin can result in diabetes, and this is seen in somewhere between 13 and 23% of patients with hereditary hemochromatosis. Can also deposit in the pituitary gland that can result in hypogonadism. So in men, we can see issues with sexual function. This can also affect bone density. In women, we can see from this deposition loss of normal menstruation or early onset of menopause. Up to 25% of people with hemochromatosis may have osteoporosis or thinning of the bones. And we can also see iron deposition in the thyroid. There's an 80-fold increased risk of developing low thyroid or hypothyroid among men with hereditary hemochromatosis. In the joints, we said this is one of the most common complaints that may bring patients to the doctor and lead to identification of this condition. The most common joints affected are shown in this picture here. So in the hand, the proximal interphalangeal, or sort of the middle joint of the finger, or the knuckle joints, if you will, are commonly affected. And in terms of distinguishing this particular condition from other types of arthritis, there are some features on x-rays that radiologists can use to help identify that this may be the cause of arthritis. Typically, this is a symmetrical condition, so we'll see both sides of the body affected fairly equally. And it can either affect a single joint or multiple joints. You can see here, in addition to the hands, some of the other joint areas in the body that may be affected. The heart can be affected by iron deposition, and this can affect both the electrical conduction system within the heart as well as the heart muscle itself. So iron that is collecting within the electrical conduction system can affect the normal heart rhythm. So we can see arrhythmias develop. One of the most common of these is atrial fibrillation. This can also, if it's infiltrating the heart muscle, can result in either a sort of a large dilated floppy heart that isn't pumping well, or the heart muscle can become very stiff and hard, and that can also impair the normal function of the heart. So we can see some patients develop congestive heart failure related to iron overload from hemochromatosis. So moving on to discussing the liver. So how can iron overload manifest in the liver? How do we discover this? So first of all, liver, of all the organs, liver is the most commonly affected organ that we see in type 1 hemochromatosis. It tends to be asymptomatic unless we are discovering it rather late in the course of disease, where patients may have more advanced liver injury that in itself can cause symptoms. So shown here on the slide are a number of the ways that we might discover that the liver is affected. So we may see patients who are referred to see us in our liver or GI clinics because their primary doctor has discovered that their liver blood tests are elevated on a persistent basis. And as part of our investigation for causes, we might identify that there's abnormal iron studies present. Sometimes we discover this in the course of evaluating other types of chronic liver disease. So I may see someone in my office who has underlying alcohol-associated liver disease or hepatitis C, and in part of my evaluation to see how much that has affected the health of their liver, may discover that there are also issues present with iron overload. Patients who may have more advanced liver injury may have some symptoms, including pain, that can bring this to our attention. Sometimes we discover this because it's a genetic condition, because we're screening the relatives of other individuals who have been identified with hemochromatosis. Sometimes this is what we call an incidental finding or accidental finding, meaning we weren't looking for this in particular, but we found it while we were doing lab tests or imaging studies for other reasons. We can sometimes find this, maybe we weren't suspecting it, but we were getting a liver biopsy for another reason, and our pathologists routinely stain liver tissue for iron, and so they may report back to us that in addition to whatever else they're seeing in the liver, that they also see some iron buildup in the liver tissue, or that patients maybe had not been identified until their liver disease was fairly advanced, and so we may identify it in patients who have been diagnosed with cirrhosis or liver cancer. So why is the liver so commonly affected? Why is this the most commonly affected organ? Well, this really gets to, circling back to our initial discussion about how iron is absorbed in the body. And we said that this happens in the intestinal tract. Once that iron enters the bloodstream, that bloodstream sort of trickles or works its way into the main blood vessel that's serving the liver, that's called the portal vein. So the liver is really first stop for blood coming out of our intestinal tract. The liver filters that blood and helps to metabolize the nutrients that are delivered, helps to metabolize drugs and eliminate toxins. And so the liver is really sort of first line. And so it's receiving sort of the highest concentration of iron once it is absorbed, and thus is most prone to accumulating or building up iron once it's been absorbed into the bloodstream. So in patients who are absorbing too much iron because they have this underlying genetic predisposition, how can this affect the health of the liver? Well, it can cause, and this is what we see most commonly, mild and asymptomatic injury to the liver. So the sort of good news, bad news about the liver is that it typically does not produce a lot of symptoms when there is a mild injury present. And this is a good thing in that that tends not to cause people a lot of pain and suffering, but it also means that it can be easy to miss many liver conditions if we're not screening for it, such as just getting routine liver panel when we're doing routine health examinations. Over the course of time, similar to any other chronic liver condition, if there is persistent injury present, this is the trigger for or can result in progressive fibrosis. So fibrosis is scarring that is part of the liver's response to injury. And if this is an injury that persists over the course of years or decades, we can see that fibrosis accumulate as time goes by. And ultimately, if that fibrosis becomes severe, this is what we call cirrhosis. So cirrhosis of the liver can be caused by many, many things, including iron overload. When we are evaluating patients with hemochromatosis, we recognize that the degree of ferritin elevation at the time of diagnosis can provide us with some important prognostic information, including the likelihood or risk of someone developing cirrhosis. And we know that once the ferritin is at a level of 1,000 or higher, when people are being diagnosed, that they are probably have experienced a much greater long-term accumulation of iron that increases the likelihood that they may have severe scarring or severe fibrosis present. As cirrhosis progresses, we can see what we call advanced or decompensated cirrhosis, where people experience complications. And one of the complications we can see in this and other causes of cirrhosis is primary liver cancer or hepatocellular carcinoma, which I've abbreviated as HCC in this slide. We recognize that in patients who are C282Y homozygotes, if they have an elevated ferritin greater than 1,000, in combination with elevated ALT and AST, these are the liver blood tests that we monitor as an indication of liver inflammation or injury. If they have elevated ALT and AST, very high ferritin, and a low platelet count, so if the platelet count is running below a level of 150, that people meeting that sort of combination of factors, more than 80% of them will have cirrhosis present. So one of the questions that often patients ask if they're seeing us for evaluation of liver disease that is not primarily caused by alcohol is, well, if I have a non-alcoholic liver condition, is it okay for me to drink alcohol? And as for many other causes of chronic liver disease, we recognize that adding alcohol into the picture when people have iron overload can really markedly increase the risk for them to go on and develop more serious liver injury. So my goal in practice, whenever I have the opportunity to help reduce risk for long-term serious liver complications, so for developing cirrhosis, for having someone who may have early cirrhosis and go on to develop complications from their cirrhosis or need a liver transplant. Any opportunity that we have to reduce risk, we want to take. And minimizing or avoiding alcohol use is one of the best means of lifestyle modification that we can adopt to help protect people from developing complications. And so we've shown here the combination of hemochromatosis with moderate to heavy daily alcohol use markedly increases the risk for developing cirrhosis. And shown here is a picture just to sort of remind us all what a single drink equivalent looks like. So the type of alcohol, if we're talking about risk for liver injury, really is not so in and of itself important as the combination of what type of alcohol, because that determines strength, along with how much and how many drink equivalents really helps to speak to the risk of that alcohol use resulting in significant liver injury. So we typically will counsel patients to really abstain from alcohol to reduce risk for added injury. What about the risk for developing liver cancer in people who have hemochromatosis? Well, this is a risk that emerges in patients who have more severe fibrosis or liver cirrhosis. And the risk of developing this primary liver cancer in people who have cirrhosis from hemochromatosis over the course of 10 years, that risk is about 6 to 10%. We see, pretty much across the board that men tend to have higher rates or risk for developing this primary liver cancer. We talked a moment ago about how the serum ferritin at the time of diagnosis can help in predicting risk for cirrhosis. It can also indicate risk for hepatocellular carcinoma if that value is greater than 2,000. And we see that liver cancer accounts for nearly half of the deaths that occur from cirrhosis caused by hemochromatosis. So one of the really important messages here for patients and for providers taking care of them is to do appropriate staging of liver disease once we've identified that somebody has this, because this will tell us as liver providers whether we need to initiate screening for liver cancer, which is our best opportunity to identify it early and offer potentially curative treatments. So what diagnostic testing do we do in patients with suspected iron overload? We discussed this earlier. The transferrin saturation is probably the most specific thing that we can look at to indicate that there's an excess of iron present in the body. And we use a threshold of about 45% or greater. There are a small percentage of patients who may have an elevated ferritin without having a transferrin saturation over 45%, although the most common pattern we see is the high transferrin saturation. So how can we demonstrate in patients who have hereditary hemochromatosis that they actually have an excess of iron present in the liver? Well, one of the ways we can do this is through liver biopsy. So we're looking here at a cartoon of a biopsy being taken. The middle picture here is an appearance of a normal liver under a microscope once it's been stained. And the third picture is using a special stain that helps to highlight the presence of iron called a Prussian blue stain. And all of this blue is highlighting an excess of iron in the liver. Our pathologists can also do additional testing to give us a sense of severity of the iron present based on liver biopsy called hepatic iron index and hepatic iron concentration. We can also measure iron, identify iron and measure iron non-invasively using an MRI. MRI is very sensitive at detecting iron. And what we tend to see is that the liver appears black on MRI, certain MRI sequences. And the radiologist can tell us quantification. So this is a nice non-invasive modality to follow liver iron concentration over time as we're administering treatment for hemochromatosis. So why would we do a liver biopsy if we can measure iron using MRI? Well, conditions where the biopsy can help us is if we think that there is both hemochromatosis plus another form of chronic liver disease. We may need to use biopsy to help us determine how much each of those two conditions are contributing to the severity of someone's liver disease to help guide our therapy. This can be helpful in identifying secondary iron overload, which has a little different staining pattern in the liver. It also allows us to perform what we call staging, meaning is there fibrosis present? And if so, how much fibrosis is there? So many of the tools that we are often using in other chronic forms of liver disease, what we call elastography. Often we use the term fibroscan to refer to this very sort of quick and easy test that we can do in our clinics. This is a test that helps to measure the stiffness of the liver tissue that helps us evaluate or estimate how much fibrosis might be present. At this point in time, this modality, this test, is not validated for patients who have iron overload in the liver. So the iron itself can make the liver tissue stiffer. So if we're estimating liver stiffness, we might overestimate how much fibrosis that means. So right now, if we are concerned that somebody may have liver fibrosis from hemochromatosis, we are still reliant on using liver biopsy to evaluate that. So when do we need to treat iron overload? So among our patients who are C282Y homozygotes, so they have 2 copies of this gene mutation, we need to administer treatment for hemochromatosis when the serum ferritin and iron saturation levels are elevated with thresholds shown here. The higher threshold in men or postmenopausal women and lower threshold in premenopausal women. What about our compound, sticking with this group who have the C282Y mutations, if they have a normal serum ferritin, then these are individuals who we're going to monitor with repeat iron levels over time to determine if they're reaching a threshold where treatment should be initiated. And our patients who are compound heterozygotes, so they have C282Y plus H63D. Again, we're going to monitor the iron levels on labs, but because this is a little bit lower risk gene combination in terms of manifesting iron excess, we typically don't see that patients need to be treated for the iron overload unless they also have other factors present that we know can influence the severity of iron levels. So these are things like fatty liver, diabetes, heavy alcohol use that can influence the manifestation of iron overload. So the mainstay of treatment is with therapeutic phlebotomy. And there are 2 phases to phlebotomy. There's an initial phase, so when somebody is initially diagnosed, when they're going to tend to have the very highest iron levels, then we're going to take blood more frequently. So typically we'll take initially 500 milliliters or a half liter of blood every week or every other week. When we do this, we need to monitor the hemoglobin level to see if people are becoming anemic from the phlebotomy. And the goal is to make sure that we're keeping the hemoglobin level above a threshold of 11 so that people aren't typically experiencing symptoms related to anemia. And monitoring the ferritin along with that, with the goal of getting the ferritin level down to the 50 to 100 range. Once we reach that 50 to 100 range for ferritin, then we switch over to maintenance phase, where over time we're aiming to keep that ferritin close to 50 or somewhere between the 50 and 100 range. Typically, this can be done with 4 or so sessions per year, although this is quite variable person to person. Because iron is best absorbed in an acid environment from our gut, from our intestine, using potent medications to reduce the acid produced in our stomach that are called proton pump inhibitors. These are drugs like omeprazole, pantoprazole, lansoprazole. This can decrease the amount of iron absorbed from our gut, and so that might reduce the frequency of maintenance phlebotomy sessions that are needed. Can we donate blood if we have hemochromatosis? Can these units of blood that we need to take off of our patients, can these then be used to transfuse people who may need it? The answer is yes. So the FDA does approve of this being done, though because it does add a little bit of layer of complexity for the organizations managing the blood donation, it's not something that is universally offered. So the Red Cross, for example, does not currently accept donations from people who have hereditary hemochromatosis, but the San Diego Blood Bank does. And I confirmed with them just prior to putting this talk together, and they provided me with this phone number. So if you are a patient with hemochromatosis and you require therapeutic phlebotomy and you would like to see your blood then used to help support other individuals who might need a blood transfusion, the San Diego Blood Bank is a place that you can do that, and their phone number for scheduling is shown here. Are there any other ways to treat hemochromatosis than phlebotomy? So this is with the use of what are called chelators. Chelators are drugs that basically sort of are given and they absorb or sponge up a particular element. And there's different type of chelators available, including chelators that specifically absorb iron from the blood. There are 3 such drugs that have been, I've got low battery. I'm gonna find a power outlet here. But we'll keep talking while I'm doing that. There are 3 such drugs that are approved by the FDA for chelation. And these are used or approved for use in patients who have secondary iron overload. So not hereditary hemochromatosis, but patients who may have iron overload related to repeated blood transfusions. So they may have underlying anemia and are not able to be treated with phlebotomy. The drugs can be associated with more side effects and certainly more expense, and are not as effective as phlebotomy. And so this is why these are not utilized routinely. In terms of diet in patients with hemochromatosis, we do recommend that you not take iron supplements or prenatal vitamins that can have increased iron content. We also advise not taking vitamin C supplements because this sort of acidic supplement can increase the absorption of iron from the gut. Also, we don't tell people that they specifically have to avoid meat or other iron-rich foods, though this can offset the frequency of phlebotomy that may be required. We do see that people with hemochromatosis have an increased propensity to certain types of infections, including this one here called Vibrio vulnificus. And this is an organism that lives in aquatic environments, so it can be acquired through cuts or abrasions in the skin and absorbed into the body that way. It can also be acquired by eating certain shellfish like oysters or mussels if they haven't been cooked. So we do recommend that patients with hemochromatosis and other types of chronic liver disease really avoid consuming these raw shellfish. What about liver transplant? Liver transplant cures the underlying liver disease and also normalizes the underlying iron metabolism abnormality. So it is curative for the hemochromatosis itself. And so the indications for this are patients who have really advanced end-stage liver disease or liver cancer. It has equivalent survival to transplant done for other indications. Because patients who are in need of liver transplant are often sicker, they may not tolerate phlebotomy, and that's okay. That's something that doesn't have to be done in order to undergo transplant safely. So what about screening? When we identify somebody with the C282Y gene mutations, the person affected by a genetic disorder, the medical term for that is the proband. So in this cartoon, dad is the proband. So what do we do about checking the children in the family? Well, the primary recommendation is that we actually screen mom, because if mom doesn't have any of the gene mutations that can produce hemochromatosis, then the kids will have one copy of the gene, but we know they won't have a second one present. And so that is the recommended means of screening families. We do know that this individual, their sibling, is at risk and should absolutely be screened because they may also be afflicted. And if this individual has heavy iron loading with their mutations, the sibling is likely to as well, because of both shared genes and environment. And so I believe this is my final slide. I'm going to show you just sort of an overview of screening. So we would screen with the serum transferrin saturation and ferritin. If the transferrin saturation is under 45%, the ferritin is normal, then we're done. If this is not true, then we want to screen for the HFE genotype, that gene testing. If we find that someone has 2 copies of C282Y, if they have a very high serum ferritin or elevated liver blood tests, then we want to go to liver biopsy to stage or identify if there's fibrosis and how much fibrosis might be present. If their serum ferritin is below 1,000 and the liver tests are completely normal, then we can skip the staging biopsy and go straight to initiating phlebotomy to remove the excess iron. In our compound heterozygotes, so those are people who have 1 copy of C282Y and 1 of H63D, then we evaluate look to see if they have other conditions present that can influence iron metabolism. This is a great setting to use MRI to see whether they may have iron loading in the liver, given that this is more variable in these patients, but may also want to consider liver biopsy selectively for staging and to initiate therapeutic phlebotomy. So with that, I think I am to the end of my presentation. I thank you all for your attention. I thank you for the opportunity to speak with you, and I'd be happy to take any questions that you might have.
Thank you so much, Dr. Patton. That was so great. You can hear me, correct?
Thank you. I can hear you, yes.
Okay, perfect. Just making sure I turned myself on correctly. So, couple of questions. Actually, one from me as well. Getting into like that genotype versus phenotype in the beginning, that can be a little complicated. So
yes,
you have a patient, genotypically, right? Their blood work comes back that you should be concerned, but you evaluate and it really doesn't seem like they're expressing, right? Is that something you rely on to say, I'm good, and like in your last slide, you're done? Or do you find that phenotypes change over time and you'd monitor them?
So if I was diagnosing particularly a younger person, the message for that individual is you might not be manifesting iron overload right now, which is great, but I would say at a minimum, we would want to recheck iron studies annually, recognizing that as time goes by, that the amounts of iron could reach a threshold where we would want to initiate treatment. That's really an ideal circumstance to find somebody in, because it means that we could sort of get on top of the therapeutic phlebotomy as soon as the iron was getting to be in excess, and really avoid any organ damage that could occur from the iron excess.
Understood. Now, actually transitioning, right, as you just mentioned, that organ damage, and not so much, well, actually, I'll start with that, yes. With the end organ damage that can happen from hemochromatosis, if you correct it, right, so you found it probably more progressed, do you see that can improve? Or say if someone's already manifesting symptoms of like cardiac dysfunction, that's their baseline and they don't really recover?
Right, so it varies by organ system how responsive it is to therapeutic phlebotomy. In the liver, if we are identifying and initiating treatment prior to developing cirrhosis, or in potentially very early cirrhosis, we don't necessarily anticipate that people would become non-cirrhotic, though we potentially could impact their future risk for things like HCC or decompensation. But if we catch involvement prior to the cirrhotic stage, we can absolutely change trajectory and avoid people going on to develop cirrhosis in the future, assuming there isn't any other factor present. The arthralgias unfortunately tend not to respond so well. So the joint pains tend to persist despite therapeutic phlebotomy. And cardiac, I think, is not always routinely reversible, the damage there with phlebotomy.
And then also, right, everyone is very aware of the physical manifestations, and I'm sure people notice, right, that skin bronzing. In your experience, have you seen that improve?
I have to say, I don't know that I have truly seen somebody with real bronzing. The original medical term for this condition was bronze diabetes, because it was recognized that people developed skin bronzing and diabetes together. I think now, fortunately, because and fortunately for us living in a developed country, developed society with healthcare, we probably don't see as many people with more advanced disease who haven't been identified before it gets to that point.
Good. It's always like progress.
Yeah.
And then there was a question that I think you answered, but I'm just going to reiterate it. For patients who have other conditions, right? Like say like a chronic kidney disease, they're baseline anemic. That's when you would use one of those kind of chelating agents, right? When you just cannot phlebotomize.
Right. That's right. So phlebotomy is far and away the most efficient, effective way to do it. But we can't safely phlebotomize somebody who has anemia for whatever reason. And so those are conditions where we would utilize a chelator drug.
Got it. And then my curiosity with because I know we focused very much on like the primary tonight, right? But you had briefly mentioned other causes of iron overload.
Yes.
Are other causes also treated like with phlebotomy, or are they more like, and that's a huge question. I'm just wondering if the treatment changes ever so much.
So we tend not to utilize phlebotomy for secondary iron overload, but rather to target the underlying driver of the iron overload. So for example, if we have patients with alcohol-associated liver injury who have, sometimes patients with very severe alcohol-associated liver injury, when we first diagnose them, say they have not had a period of sobriety, you check their iron levels, they can be just off the charts. I've seen transferrin saturations in the 80–90% range. And the treatment there is sobriety and time, and those numbers will normalize over time typically. So that's really the most effective way to treat it. There are these other conditions, so that even other primary causes that we don't have good screening tests for, genetic screening tests for. And so this is where if we had a biopsy and saw that the iron was just packed with, or the liver was packed with iron, then we might say, this is a circumstance where we think therapeutic phlebotomy might have a role.
Got it. That was the last of my questions. If anybody, I'll give a couple of moments just to see if anybody has a couple of last ones, but it looks like we are over time as well. So thank you so much. That was very comprehensive and entertaining. So thank you so much. And thank everyone for joining us. We really hope you'll continue to join us for the series of these webinars, and have a great evening.
Thanks, everybody.